Hello, this is Dr. John Bennett broadcasting from sunny Miami in the afternoon. We have the pleasure today of having uh, Peter. I'm sorry, Peter Galkin, MD. He's a neurosurgeon from Moscow. He did another hangout with us about 8 months ago or so. Excellent presentation, and he's going to give a presentation on saphenous grain graft and treatment for cerebral artery occlusive disease. And we're joined on the panel. Let's go around and introduce the panel before we turn it over to Peter. Hello, Slaven.
Hello everyone, my name is Slaven Gojkovic. I'm here in Zagreb, Croatia, and I'm a great fan, and I'm looking forward to learn from Dr. Peter in his presentation.
And the old stalwart, Simon.
Hello, Dr. Galkin. It's very nice to see you again. I'm looking forward to your presentation. Thank you very much.
And a new arrival, Rakesh.
Hello. Hi, I'm Dr. Rakesh from Neurosurgeon from India. Glad to hear you, Dr. Peter.
And Peter, Rakesh just finished his boards today.
Yeah, just today.
So you remember that, Peter, those days. And I believe Majed is away from his desk. So I'll turn it over to you, Peter. It's all yours. Welcome back.
So I can start?
Yes, please.
Yeah. So do you see the picture?
Yes, it's very good.
So this stroke is the third most common cause of disability, and second common cause by death worldwide. Especially it is spread in the eastern part of our planet. As reported by the World Health Organization in 2014, we had almost 450,000 of deaths caused by stroke in Russia, and the stroke is the second place of death after coronary heart disease in Russia. About 58% of all strokes are ischemic strokes, and in 15 to 25% the result of internal carotid artery occlusion. Mainly it's atherosclerotic occlusion. Here you see the typical MRI and angiographic presentation of internal carotid artery occlusion with a hemispheric stroke on the diffusion weight image. The estimated worldwide 30-day case fatality rate after first ischemic stroke is about 20%, and about 50% of all ischemic stroke survivors have different disabilities. About 50% patient had hemiparesis, about the same amount of patients had cognitive deficits, and about a third of all patients has depression symptoms. The surgery I will talk today is an extra intracranial bypass that was proposed by famous neurosurgeons Yashardil and Donahue in 1967. The aim of this surgery to bypass blood through superficial arteries that has a course under the skin of the head to allow the blood to allow blood flow against the occlusion of internal carotid artery. This surgery makes through trepanation in temporal region, and with the use of microsurgical instruments and the microscope performs the anastomosis with superficial temporal branch artery to cortical branch of middle cerebral artery. This surgery was the aim of the surgery initially was to make bypassing occlusive process in cerebral arteries that are not accessible by other surgeries. But in 1985, intracranial bypass study had shown that this surgery do not improve long-term results in comparison with best medical therapy. It was just aspirin consumption. Here's the results of the study. Similar results derived from a carotid occlusion surgery study that was terminated in 2010. Similarly, among the patients with recently symptomatic internal carotid artery occlusion, hemodynamic cerebral ischemia, extra intracranial bypass surgery plus medical therapy compared with medical therapy alone did not reduce the risk of recurrent ipsilateral ischemic stroke at 2 years. But there are several weak sides of carotid occlusion surgery study, such as positron emission tomographic criteria that was used in this study did not were insufficiently convincible to reveal patients with high risk of cerebral ischemia and progression of it. Also, the another weak side was amount of bypasses performed by every surgeon were too small. 30 surgeons made 93 bypasses, so it is difficult to judge about method unification. Also, stroke incidence after bypass surgery in the study was too high. It was 15%. As a result of this cost study, health insurance companies do not cover expenses for the ECIC bypass surgeries in Western world. This type of surgery continue to use in Eastern countries such as Japan, South Korea, China, and also in Russia, because of considerable amount of patients that suffer from hemodynamic cerebral insufficiency due to occlusive cerebral artery disease. So my research work was to assess ability to improve cerebral blood flow by different methods, and in cases when there was not a good donor artery, I suggested to use Saphenous vein graft from the shin. Between October 2010 and March 2014, we performed 71 ECIC bypasses in 69 patients. In 2 patients we made it bilaterally. In 22 patients of these 69 patients, we used interposed Saphenous vein graft between superficial temporal artery trunk and cortical segments of middle cerebral artery. The reasons for use of a venous graft were a small diameter of superficial temporal parietal branch. It was about 0.9 millimeters in 14 patients. Also, the absence of palpable pulsation of or visualization at CT angio and insufficient blood flow after its transaction. But the diameter in these cases was pretty enough, about 1.5 millimeter. We observed it in 6 patients. Also, in one case, it was inadvertent damage of superficial temporal artery and the rostral dystopia of in one patient. This is a vein, and we cannot pull this artery to perform bypass here in this region. Here in this CT angio, you can see the absence of superficial temporal artery branch, so we need to perform bypass from trunk of superficial temporal artery and to put it through the trephination in skull. Here is a. So now, John, I will improvise because this is my presentation that I made in Seoul, Korea in 2013. Here is a here we to reveal what. Just a moment. Here are the typical CT. Just a moment. Here's a typical CT angio of patients that we perform bypasses. This is a patient with occlusion of internal carotid artery. This patient has occlusion with a stump of internal carotid artery. This stump could be a source of embolus if you perform AMCA bypass with using of this superficial temporal artery branch in future. So we did 2-stage surgeries in these patients. We perform resection of this stump and then perform cranial stage. Also, in this patient is a hypoplasia or probably subocclusion. I think that yes, this is a subocclusion of contralateral internal carotid artery. This patient is with a MCA, severe stenosis, M1 segment. Here is just a video, but this is not vein in this position. It's temporal artery. It's a short video after the surgery was made. This is a Sylvian fissure, and this is a division of M3 segments of MCA. Here is anastomosis. This is a short video of the use of vein graft to the middle cerebral cortical segment of middle cerebral artery. Also, this is the final step of surgery. We usually perform trepanation. Here is a this is a magnification of the created bypass. This is a vein that is sutured to a cortical branch of middle cerebral artery. So now mean follow-up is about 2.5 years, and we assess. Now I usually assess only clinical improvements because we cannot in Russia we don't have acetazolamide or Diamox to assess cerebral reserve with perfusion techniques. But at the early stage of my scientific work, I assess the results with CT perfusion without acetazolamide probe, and we assess usually. I assess usually CBA. This is a cerebral blood flow and mean transit time asymmetry that we can get from CT perfusion. Also, clinical symptom dynamics and ischemic event-free survival in graft patency. This is a typical CT perfusion in patient with a big ischemic stroke. This was a result of CT perfusion before surgery, and this is a result after surgery. Here you can see this is a blue zones. They reflect that here is not enough. There is not enough blood supply of the brain, and here they become green. Also, we can see the growth in cerebral blood flow. This is the amount of blood that goes through the 100 of grams of brain. Here's the amount of contrast in milliliter that goes through 100 of grams of brain during 1 minute, and this is a mean transit time. Also, this is a digits. They reflect how fast the contrast agent goes through the amounts of brain tissue. It also becomes lower. So here is improvement in the vascularization of brain after our surgery. This is a result of this series. We observed improvement in 80% of patients after our bypass surgeries. 10% said that they didn't feel any changes, and 3 patients got worse. So, if analyze the results of CBF and mean transit time dynamics that we got with the using of CT perfusion, we we see that the results are not correlated with the clinical symptoms. This is the main thing that I think that this CT perfusion was made without acetazolamide load. During our surgery, we have a 30-day event rate. In 3 patients, we had 1 minor ischemic stroke that happened during first 24 hours post-surgery. Also, we had a patient with 1 transient ischemia of brain. It was on the 3rd and 8th day post-surgery. And also we had 1 focal seizure syndrome in the patient. It was on 15th days post-surgery. 30-day ischemic event-free survival was 93%. And the graft patency that was verified with duplex was 93% in follow-up of mean 1 year. So there's a conclusion. I just want, it's not, I not finish. I want to show you some other. John, I will just a moment. I will show you another pictures.
Okay.
That I think that it will be interesting.
Okay.
Mm-hmm. Okay, that's fine.
You okay, Peter?
Yes, I'm okay. Just a moment.
Okay.
Hi. Yeah, here is it. Just a moment. I will open these pictures. I'm opening it.
It's not working?
Yes, it's working. It's okay. I because
Okay.
I didn't get. I started to do this presentation today in morning, and I didn't get.
Okay.
I didn't manage to finish it.
Okay.
Just a moment. No. Really.
While we're waiting, Rakesh, have you ever assisted on an operation like this before?
No, I have unfortunately I have not yet assisted such procedure, but I went through this history of Yasir Gil, who was first to perform this ECIC bypass. So I just wanted to, after the presentation gets over, I just want to ask him what was the first material used for the bypass and what is the standard now?
Okay. Well, I think he wants to show us a few more pictures, and then we can ask him some questions. You want to show us some more pictures, Peter?
Yes, here you can see in geography. This picture was made in 6 months after IC bypass. It was a Saphenous vein graft was used in this patient, and here you can see that the blood is it goes to the division of M2 segments of middle cerebral artery. Here is it's occlusive disease of here's the internal carotid artery occlusion. It works. This bypass. Also another one. Do you see this? Do you see another one?
Yes.
Here is also Saphenous vein graft, and it is marked with blue arrowhead, and this is STA is marked with red arrowhead. Here is a narrowing of STA, but it's not stenosis because the diameter of vein is usually increases the diameter of artery maybe 2 or 3 times. Sometimes the vein at the shin is the diameter of vein at the shin is 4 millimeters, and STI trunk is about 1.5 millimeter. Also, this is a picture how we see blood flow at the duplex after surgery. Here's the skin, and I think that here is a bone and how the vessel goes through it. Also, this is a final view how we see it in microscope, neurosurgical microscope. Here is a trunk of a superficial temporal artery. This is a vein that goes too big. That is goes through this sulcus, through this groove under the dura. This is a picture before. Before we cover it with a bone, we usually put rare sutures of PGA sutures. So also, this is how it looks. You see this is a different diameter. It's maybe I think that this artery is about 1.2, 1.1 millimeters. So, and I go from the end to the beginning, and this is a trunk of superficial temporal artery, and here's the swing of the posterior far side of anastomosis. Now this is just a text. This is you already show it here. So John, maybe anybody who has any questions? I think that I finished.
Yes, thank you, Peter. Very well, fascinating pictures, and man, it must take such precision. I'm a non-surgeon, but to operate in areas like that. And as we usually do, we start off questions by a neurosurgeon on the panel. So why don't we start off with you, Rakesh? You have questions for Peter?
Yeah, hi, Dr. Peter. It was a very nice presentation. In fact, the last few photographs which you showed were very nice. It took time, but it was worth showing those pictures. One thing I wanted to ask is when Yasirkil did the first procedure, what was the graft used, and what is the standard now? And one more thing, I heard that in Moyamoya disease they do a STA MCA bypass graft. How that is different from this?
So for me, the John, John, do you see me?
No, Peter,
No.
not yet. You have to get off the screen share. Just click on it again. Click the arrow again. You're still on the screen share.
How I can
You click on the green arrow on the menu. There's a
Uh-huh.
green arrow.
Yes,
On the-
I did it.
Yeah, click on that green menu. You should come off the screen share if you click on the green arrow in the menu.
Extreme left.
Yeah, the far
Yeah,
left.
I try, but I here is this now.
No, not yet. Not yet. Click on the arrow. Yeah, okay. You're not off yet?
The button says stop sharing.
Well, you know what, dog? It might be a bug.
There's a button that says stop sharing also at the bottom of the screen.
You know, Peter, that's okay. That's okay. It must be a little bug in the system, but you can just might as well just finish it off. Well, there you go. There you go, Peter.
Here you are.
There you go. Okay,
So,
what were you saying, Peter?
yes. Now, for us, the standard of use, we usually do such surgeries if we don't have appropriate donor vessel. You see, the vessel is 1 millimeter, or it is smaller in diameter. I take the donor vessel. It is a vein graft. I usually take it from a shin, from the distal shin, and just above the internal malleolus. Yes.
Yes, malleus.
Malleus, yes. And usually I harvest about 9 centimeters of the vein, and I just transect it and I put it into the solution with a papaverine. It's a medicine that prevents spasm, and after I open superficial temporal trunk, I perform proximal anastomosis of the vein with it, and then I perform then I open dura, and I try to find the appropriate cortical middle cerebral artery branch, and I do the trepanation for in a diameter maybe 4 to 5 centimeters, so I can find appropriate artery. I use the biggest artery. It's good when the artery, the cortical artery, has a diameter more than 1.5 millimeters, but it's not problem if the artery is 1 millimeter in diameter. If you do the trepanation, it is possible to find from 2 to 3 MCA M4 segment arteries, and you can choose the best artery with a good diameter. So when I perform when I finish the second anastomosis, I cover dural layer, and then I put the bone and fix it as a silk sutures, and then I close the wound. I usually put to the place where the bypass goes through the bone. I usually place there silicone drainage that is stays in, and it goes out from the wound. between sutures, and it usually is, I leave it until next day, and so patient is observed in ICU until next day. If there is no problem, so we take him back to our department, and as usual he's leave hospital on 7th or 8th, maybe 9th day after surgery. Standard for me, the standard for such surgery is a ischemic symptoms in patients that patients experience. It is very difficult to differentiate. It's not simple to differentiate. I usually perform before surgery to choose a patient for the surgery. I usually perform transcranial. Ask my colleagues to perform transcranial duplex if the asymmetry blood flow on M1 segments of middle cerebral artery is more than 40%, and if patient has complaints like tardiness or speech disturbances or headaches, I usually take him to the surgery and perform it. As I said, here in Russia we don't have a positron emission tomography. It is not widespread. It's a very expensive equipment. I need
Peter,
to.
Peter, go ahead. Do you have another question, Rakesh?
The thing is, how the surgery is different from the one done for Moya disease, that is STA-MCA bypass.
Actually, I made. Yeah, I made such surgeries. I made two venous bypasses to young ladies with Moya disease.
Okay.
I had this experience. Yes.
Okay, you don't do a bypass graft there, is it?
But yes, I need to I assess the donor artery first. If the donor artery is if I don't have a good parietal branch, if the parietal branch is very small, yes, if the diameter of parietal branch is less than 1 millimeter, and I cannot feel its pulsation under my fingertips, yes, or if at CT angio I cannot see it on CT angio, I plan to take a venous graft from the shin. Actually, there is no problem, because when you open the wound, when you open the skin, and you can make the region of parietal branch. If it's enough wide, if it has a good pulsation, when you transact it, you see good blood flow from it, you can use it as a donor artery. If there are problems, you just open skin at the shin and take from there venous bypass. There are no problems.
Sure. Thank you.
Yeah, I have a question, Peter. If there's bleeding, how do you stop it?
If there's bleeding,
yes.
I usually put additional sutures, or sometimes we can use such material like tachocomb. This is a material that has a chemical reaction across the along the place where the wall of the artery and vein has some distance. You see, because there is a not very this is a surgery very delicate, and it's a not big artery. You can sometimes this bleeding you can close with a special material, or maybe with a Surgicel, spong. It's not a problem. Sometimes in microscope at magnification you see that it's a very huge bleeding, but it's real. It's not big. And also, if there is a small bleeding, it's not a problem, because you could place. I usually place a drainage, and this is a exudation. This one drainage goes out, and actually we had maybe 2 or 3 cases among the 70 patients of subdural hematomas, but they were very small. They didn't. They don't need to be evacuated.
Okay. Okay. Well, any closing comments, questions? Well, anyways, Peter, thank you very much for taking the time for an excellent presentation.
Thank you, John.
Someday we'll all meet at your dacha on the Black Sea.
Dacha.
By the way,
Dacha.
what was the last?
Dacha.
Actually,
We'll meet at dacha and we'll drink Ruski vodka.
No, I don't. I don't drink Ruski vodka.
I don't think.